Assalamu alaikum. Good morning, everyone. So today we'll have a lecture about upper GI bleeding. The take-home message of this presentation is to know like the different or various reasons of upper GI bleeding and how to differentiate between them in the clinical scenarios. Okay, not how to treat, how to manage, how to do surgery. Okay. So, we have to also understand the concept of upper GI bleeding. So, if from the name, like there is like two different aspects of GI bleeding, upper and lower. So, what's the division? What's the landmark that we are using in order to categorize the bleeding into upper and lower? Ligament of Treitz. Okay. So what do you mean by that? What's the ligament of Treitz? So it's a fibromuscular structure that's forms the division between the duodenum and the jejunum. Okay, so it maintains the flexure between the duodenum and jejunum. All right, and also it's the landmark that's been used in order to differentiate between the source of bleeding, the location of bleeding. Okay, so above the ligament of Treitz, we have upper GI bleeding, and lower than that, it's lower GI bleeding. But how does it make a difference? So why are we doing that division? Presentation and so so the symptoms and also the way to investigate as well. Okay. So in terms of symptoms, so for the upper GI bleeding, what are the symptoms that usually patients present with? And what do you mean by hematemesis? Vomiting blood. What else? Melena. So what do you mean by melena? Black tarry stool. So black tarry stool means that it's a digested blood already, and it's there in the content of the stool. So it's not a fresh blood rectum. Okay. What else? Site of pain. No, we have also coffee ground emesis, which is also um, like a like type of upper GI bleeding. All right. In addition to that, sometimes before we go into that, what are the symptoms of the lower GI bleeding? Hematochezia, which is fresh blood per rectum, and that's it. Okay. So sometimes, like if the upper GI bleeding is massive, so we said about the upper GI bleeding, it's coffee ground emesis, like not either it could be fresh blood like vomitus or coffee ground. And what's the difference between that? Is that it's being processed by the stomach through the different enzymes. All right. So the process or the digestion of the blood itself, it indicates that like it's there in the upper GI bleeding. Okay. However, if the bleeding of the upper GI is massive, there is no time for the blood to be digested. So maybe like one of the presentations of massive upper GI bleeding, it would be also fresh blood per rectum. So it doesn't mean that it's a lower GI bleeding. Okay. So with that being said, it's very important to know by the clinical scenario. And what do you mean by the clinical scenario? History taking and also physical examination. It's very important to know um, how is the presentation started and what are the medical background of the patients in order to know um, like what do you expect in this patient, what's the cause of the upper GI bleeding, as we will see later. So this is the definition of upper GI bleeding. So we said anything above the ligament of Treitz. And what are the structures that above the ligament of Treitz? We have the esophagus, we have the stomach, we have the duodenum, and in addition to that, the structures that are attached to the duodenum, like the liver, biliary system, and the pancreas. So any bleeder in these organs would present with upper GI bleeding. So the most common type of upper GI bleeding is bleeding from peptic ulcer disease. And I guess already, so this is like a combination or a recap of all the lectures that you guys took. Okay, so I guess you also took a lecture of peptic ulcer disease, right? So one of the complications of peptic ulcer disease is bleeding. Okay, and if we are talking about upper GI bleeding, the most common cause of upper GI bleeding is peptic ulcer disease. And peptic ulcer disease can present in duodenum, and it can present also in the stomach. It can also lead to esophagitis, like especially if it was related to H. pylori. It can also be related to gastritis and so on. Okay. The second cause of upper GI bleeding would be portal hypertension. And what do you mean by portal hypertension? Exactly. So the portal vein, which is like a continuation of the superior mesenteric vein and the splenic vein, and this goes into the liver. Okay. So if there is high pressure inside the liver, especially in cases of liver cirrhosis, then the blood will not be able to pass through the liver. Okay. So, what's going to happen after that? There would be a continuation or like a connection between the portal system, which is like the portal vein, which goes into the liver, and also the systemic veins, which goes by bypassing the liver. Okay, so there would be connections. So the body will try to bypass the liver. So the blood will go into these connections from the portal system into the systemic circulation. Okay. So what's going to happen after that? We have three major sites of anastomosis between the portal system and the systemic circulation. One of them is the esophageal varices. So the esophageal varices is a continuation of which veins? Hmm? So left gastric is from the portal system, and we have also from the systemic circulation the azygous and hemiazygous veins. Okay, so these the presence of blood and that connection would form the esophageal varices. Next, we have the gastric varices. So gastric varices is the connection between the short gastric veins and as well, we have the gastroepiploid veins from the systemic circulation. Um, And there is also like another like a special form of the gastric varices. We call it watermelon stomach or gastric antral. So it's a like acronym gave gastric antral um, variceal ectasia. Okay, so by endoscopy, you would see the stomach forms a shape of a watermelon. Okay, so this indicates portal hypertension. And then, so later in this presentation, we will go by these causes of upper GI bleeding. And the most important thing is that you correlate like the causes with the clinical presentation. So for peptic ulcer disorder, you already guys took a lecture about it. So what would be the associated causes for the peptic ulcer disease? So we have H. pylori infection, and we have also NSAID use. So if they gave you a clinical scenario with the symptoms of upper GI bleeding, and then they told you that the patient is a chronic, so the patient has severe back pain and used to take NSAIDs for a long time. So what would you expect? What would be the cause of upper GI bleeding? Peptic ulcer. So this is how you should think. Okay, I can bring like 100 clinical scenarios out of this presentation with the same symptoms, but you have to pick up the right answer. Okay. um, Portal hypertension. So what would be the clinical background? Alcoholic patient. Okay, so could be fatty liver. Okay, fatty liver which leads to cirrhosis. Okay, hepatitis. Excellent. All right. So, like this is a statistics about upper GI bleeding. So, it is considered a serious complication of many disorders. Why? Because it can be leading to life-threatening bleeding, okay, which needs to be resuscitated. However, like most of the bleeder will be stopped spontaneously, and you can see that the overall mortality is 5 to 10%, and there would be a high risk in recurrent hemorrhages, because recurrent hemorrhages would also reflect that the progressive of the disease. All right. So with the recurrent hemorrhages and coexisting medical conditions would signify how serious the upper GI bleeding. So, as we said, 85% would stop spontaneously. Age is very important because, like 50% of patients of upper GI bleeding would present with age of 60 and higher, and like only 5 to 10% of cases would require surgical intervention. So again, this is about peptic ulcer disease. So we said it's a most common cause of upper GI bleeding, and it accounts for like almost 50% of upper GI bleeding. And we already know about a lot about the peptic ulcer disease. So how it would present? So
depends on the site. If it's in the stomach, it will get worse with eating. If it's in the water,
exactly. So we have to differentiate between gastric peptic ulcer and duodenal peptic ulcer. For gastric peptic ulcer, so they would present with epigastric pain, okay, and sometimes they call it gnawing or burning in nature, okay. So with eating, you can differentiate between duodenal and gastric. So which one would increase with eating? Gastric. Why? Because we have higher acid secretions in the stomach. Okay, and which one would be relieved with eating? The duodenum. All right. So with that being said, like only 5% of patients with peptic ulcer disease would initially present with bleeding right away, like before this like pain would start. So, what are the factors that are associated with poor outcomes in terms of peptic ulcer disease? We have the severity of the presentation. So, the rate and volume of the hemorrhage, the persistent bleeding, the recurrent, as we said, and the advanced age, with also medical comorbidities like acute renal failure or also chronic heart disease. Okay, so this is not of importance for you guys because um, we are not here to discuss how we manage, okay, but how we diagnose, how we clinically think. So again, so this is about the risk and magnitude. So as you can see over here, there are certain things that are associated with poor prognosis. So age, as we said, the presence of also systolic blood pressure hypertension, because it would signify the magnitude of the bleeding, of the ongoing bleeding. Also, one of the managements of upper GI bleeding is to insert the nasogastric tube. And the importance of the nasogastric tube is to decompress the gut and aspirate the fluids inside the gut, all right? So that we can identify first the content of the aspirate, and also we try to decrease the irritation that's ongoing in the gastric tract. Okay, so if the aspirate of the nasogastric tube was coffee ground and red blood, so it would signify there would be an upper GI bleeding. And also one of the like factors that are associated with poor outcomes is the requirement of blood transfusion. So that would indicate the bleeding is very massive. So there is also an endoscopic appearance classification, and this is the most important predictor of bleeding. Okay, and this is very important. So endoscopic appearance of the ulcer is the most important predictor of rebleeding. Okay, and there is also a classification of ulcers based on the endoscopic appearance. And it would signify also the risk of rebleeding. So if the ulcer was clean, so the peptic ulcer would be very rarely to be rebleeding. If it was pigmented, then the risk would be increasing. If there was an adherent clot, if there was a visible vessel, the risk will be increasing, and so on, until we reach into an active bleeder. So this is the classification, which is called the forest classification, and it would start from 1 into 3. Okay, so 1 means there would be an active bleeding until 3, which is a clean ulcer. Okay, and these are also images which would signify the base of the ulcers. So here you can see an arterial jet, which is the active bleeding, until 3, which is clean base. This is the, again, more details about the bleeding from the portal hypertension. So mostly it would be from the esophageal varices, and it would account for 30% of cases, okay? Um and also, as you can see over here, 90% of cirrhotic patients will develop esophageal varices, and 30% of those of esophageal varices will develop upper GI bleeding. Okay? And the mortality is up to 25% with each episode of bleeding. So, um, again, the prognosis of the upper GI bleeding depends on the comorbidities, and especially here, the portal hypertension is like a serious medical condition, and also the recurrence of bleeding. Okay? So, um, so esophageal varices are, as we said, dilated veins, and they are located in the submucosa, and they communicate with the systemic circulation through collaterals. Okay, and the size would range from few millimeters into few centimeters. The site which would be more common is the distal esophagus. And there would be also some gastric varices that are located in the cardia and the greater curvature as well. So here are the collaterals that we talked about. So we have the esophageal, we have also the periumbilical, we have also the rectal. Okay. So the rectal would be a communication of the superior rectal vein from the portal system, and the middle and inferior rectal from the systemic circulation. So this is the pathogenesis of the portal systemic circulation. We are not going through the pathology. So there would be like how to determine the portal hypertension. Usually it's the difference between like the gradient between the portal vein, which is the in the portal circulation, and the hepatic vein, which is the systemic vein. So if the gradient exceeds more than 12, then there would be a high risk of developing varices. The risk of hemorrhage increase with the size of the varices, and there is also, as we talked about the peptic ulcer disease, there is also a classification for the varices, which they call child classification, and also how active the patient in drinking alcohol. So drinking alcohol actively with the portal hypertension would signify a high risk of bleeding. So, like how to prevent the bleeding from portal hypertension by treating portal hypertension itself. So these are images of the varices. So it would look, it can even be present in the it can be visible in the upper GI bleeding as dilated veins and the submucosa, as you can see over here. And they might also, like one of the management, so here you can see the endoscopic images, okay? They can also go into the endoscopy and band these varices. So they try to trim the veins that are going along the submucosa, in order to prevent the risk of bleeding. Okay, so with the banding, we are trying to strangulate the area of the veins, and it will like eventually it will be necrotized and it will slough off. Okay, and the area in which there would be the band, it will heal by itself, and eventually the vein will be back to the normal shape without these varices or outpouching. Okay, so the next cause of the upper GI bleeding would be Mallory Weiss tear. So, are you guys familiar with this term? So, what do you mean by that? Exactly. So, it's a longitudinal laceration in the distal esophagus. So, how does it form? This is very important. Exactly. So, uh, you need to understand something that the esophagus is there, and you have also the pyloric sphincter. Okay, and this is very functional. So anything that would increase the pressure inside the stomach, it will lead to the rotation of the esophagus oppositely to the sphincter, and this would make the longitudinal tears, the mucosal tears, and the distal esophagus, and also in the gastric antrum. Okay, what are the most important causes that are associated with the miliary waste here is the retching, which is forceful vomiting, which can be due to what? Exactly. So, binge drinking of alcohol and exactly bulimia nervosa. Okay. So these are the classical examples. So if they gave you uh, like someone who's bulimic and then eventually they have hematemesis or something like that. So what's the cause? Malarial waste. Okay. So this is the idea of this lecture, because even in the like for example in step one, okay, they would give you such clinical scenarios and they would expect you to answer whether it is like peptic ulcer or it's malarial waste and so on. So you have to correlate the medical background with the clinical symptoms. All right. So, Mallory Weiss, so again, the location would be in the proximal gastric mucosa and also in the distal esophagus. Um, so, associated with alcoholism, as we said, and also bulimia nervosa and other causes, which are not important over here, but very important also epileptic patients, because in epilepsy also you have the pyloric sphincter functioning and the patient is moving around. Okay, so with this forceful movement and increase in intragastric pressure, there would be a high chance of having malarial waste tears. In addition to that, maybe we will have patients who are like um, uh, like heavy weightlifting. Okay, maybe it could be associated also with constipation. Okay, so majority of these bleeding would be spontaneously stopped in up to 90%. However, the rest of the 10% maybe would require upper GI endoscopy, which would be diagnostic and therapeutic as well. So they would go into the mucosal tears, and they would also apply epinephrine in order to make vasoconstriction around these vessels, and they try to stop the bleeder. So these are the tears and the endoscopy. Okay, so again, so they are repeating the information again and again. So, as you can see over here, the management is detailed history and physical examination. Why? Because you need to know like the concept, like what was going on. Okay, if the patient is bulimic, and then you need to think of miliary waste and so on. So this is like a major principle we will go through later on in the presentation about the management of upper GI bleeding. So um, in order to stop vomiting, you need to give the patient antiemetics. Also, one of the important thing to stop the bleeding is the PPI. Why is that? Because the gastric acid might complicate the current bleeding. Okay, so it would lead to further bleeding, as in peptic ulcer disease. So that's why they give PPI drip, and usually it reaches 8 milligram per hour as a continuous infusion. Um, what else? Endoscopic evaluation and the endoscopic therapy later on, and surgery is very rarely required. Okay, the next thing is the Dwallofoy lesion. And what do you mean by that? I bet you guys did not hear about it, right? Yes. So this is a vascular malformation that is not associated with any risk factor. Okay. So out of a sudden, patient would present with upper GI bleeding, whether hematemesis or even massively upper GI bleeding, as in fresh blood pre-rectum. Okay. And by the clinical history, there wouldn't be any risk factors associated with that. Like in peptic ulcer disease, you would expect a prolonged H. pylori infection or NSAID use. Nothing of that is there in Dwallofoy lesion. So by endoscopy, they would go and see an active bleeder, or they can see also like over here it's the gastric mucosa, so they would see a vascular malformation beneath the mucosa, and in addition to that an active oozing of bleeding. Okay, so this would signify a Dwallofoy lesion. Okay, so again, it's a vascular malformation that are not associated with any identifiable factors. Okay, so how do they present? It's by painless hematemesis or melena. Like mostly, it's associated with the middle-aged people, associated with male more, not associated with any ulcers. The bleeding is massive, voluminous. The bleeding also would stop spontaneously. However, um, they need to go into the endoscopy, and they have to slowly visualize the mucosa in order to identify the bleeding, because there wouldn't be any ulcers to identify. So again, we are trying to exclude everything in order to reach into the diagnosis of Dwallofoy lesion. Okay, and the recurrence of the hemorrhage is very common, because like again it's a vessel which is beneath the mucosa. So any extra pressure to the mucosa will cause bleeding. So for Dwallofoy lesion, like mostly it requires surgery, because you need to dissect that area which has the vessels, and also you need to suture that area. So endoscopy would be there in order to stop the bleeding. Okay, but If you have a vessel which is close to the mucosa, you have to cut that vessel. Okay, next thing is aortoduodenal fistula. So we took a lecture about fistulas. So what would be the most underlying mechanism of developing fistulas?
Pressure, increase pressure.
Pressure, okay, one of it, but it's not weak point. What's the mainstay? What has to be there? Inflammation. Okay, so uh, there should be an inflammation which would create like as in Crohn's disease, as in also we will see over here a graft, an aortic graft which is inflamed, and then it causes an abnormal connection between the aorta and the duodenum. Okay, so as you can see over here, the pathogenesis. So inflammatory tract, which is a fistula, which develops between aorta and duodenum. Okay, and what could be the causes? The causes: infectious aortitis, aortic aneurysm, and the more common is a graft. So inflamed graft. All right. So again, an elderly patient who went into like who has been diagnosed with abdominal aortic aneurysm, and they put a graft, and later on they developed hematemesis. So what would be the cause? Aortoduodenal fistula. Okay, so you have to correlate with the clinical background. Okay, symptoms would be very similar to all of them. Okay, but you have to think of what might be the cause. The characteristic bleeding over here, it could be something called herald bleeding. And what do you mean by that? It would start with uh, like a few bleeding, and then it would stop, and after that it would be hemorrhagic bleeding. Okay, and this is also a life threatening because it might this is like if you are cutting the aorta, if there would be an aortic rupture. Okay, so there would be a massive bleeding and blood loss. Eventually it would lead to death. So also it's important to diagnose this patient. So with the GI endoscopy, it might be difficult. So they might need to do CT scan and also angiography in order to determine the fistula. Okay, and of course the management would be surgical in order to remove the inflamed graft and do the grafting again. Next is the upper GI angiodysplasia. So, are you familiar with the term angiodysplasia? So, whenever you hear angiodysplasia, you have also like to put into your mind there is an elderly patient. Okay? And usually it's above 60 years of old. Why? Because angiodysplasia, from the term angio means vascular, dysplasia means like malformation. Okay, so it's like thinning of the blood vessels. So it would be tortuosity and also thinning of the blood vessel walls. Okay, and they are also associated with like diseases that could lead to like thinning of these blood vessels. One of the great examples, it could be patients who have valvular diseases. Okay, so elderly patients who have valvular diseases presenting with upper GI bleeding, you have to put as the first differential angiodysplasia. Okay, So, so they are AV malformation. So this means that the disease would start in the veins and then it would go into the smaller arteries. Okay. And they are associated also with the chronic renal failure and aortic stenosis. All right. So in aortic stenosis, it would lead to high pressure inside the vessels, and this high pressure would lead to thinning of these arteries. Thinning, and also it wouldn't be that. So the characteristics of the arterial walls, it has to be like elastic. Okay, so it would lose this elasticity, so it wouldn't be able to go back to its normal shape. So that's why it would lead to a bleeding with high blood pressure. Okay. So, pathology, flat or slightly raised red lesions would be around the mucosa, and it would be also visualized in the upper GI endoscopy. Round, circumscribed, and also dilated thin wall vessels. All right. So, next we have other causes. So we have something called infectious esophagitis, and this is mostly associated with what? CMV, esophagitis, and this is associated with which disease? Immunocompromised patients. Okay, so always put that in mind. So HIV patients, patients on like immunosuppressive drugs, so they might have CMV esophagitis or Candida esophagitis as well. Okay, GERD would be also one of the causes of esophageal bleeding, uh, Barrett's esophagus, and also medications induced erosions like NSAIDs, and radiation therapy. Okay, so this is infectious esophagitis in immunocompromised patients like HIV, associated also with organisms like Candida, herpes simplex virus, and also CMV. Uh, the bleeding may be also be passive, like it would present with occult bleeding. Next is hemophilia. So from the name hemo, related to blood, bilia, which is biliary tract. So anything that would cause a presence of blood in the biliary tree, they call it hemophilia. And most likely it would be related to trauma, especially like if it was as a side effect of surgical procedures like ERCP. Uh, do you guys know what's the concept of the ERCP?
Visualize the stone.
Exactly. So the idea is that in order to visualize the biliary tree, so they would go with the endoscopy and then they would reach into the ampulla vater, and then they would go inside the biliary tree. Okay. Why do we do that? In order to remove stones which are there in the either the biliary tree, beyond the gallbladder, and the CBD. Okay, so one of the like most common complications for that, it would be hemophilia, and it would also results in pancreatitis, like as a complication of ERCP. Next thing is the duodenal diverticulum, and we explained it in the previous lectures. So, like it's the second most site of the diverticula, and we said something there would be something special about this diverticulum. What was that? The location, exactly. So, what would cause? Exactly. So it would lead to pancreatitis, it would lead to gallstone formation, it would also lead to cholangitis. Okay. And also, it might lead to upper GI bleeding. Okay. So this is the endoscopic appearance of the duodenal diverticula. So we said that in the diverticula, it's an outpouching of the mucosa. So you cannot really go into the endoscopy, but you can see the base of the diverticula as we can see over here. All right. So this is about duodenal diverticula. Next, which is the last concept of the presentation, is the basic of the management of upper GI bleeding. Okay, so for upper GI bleeding, we consider it like as a medical emergency. Okay, so it's like an ABC. So first thing is that we need to check the vital signs of the patient. If the patient is hypotensive, going into shock, so we have to save the patient first. Okay. Um, Next thing is to identify the source of bleeding. Okay. And then once you identify the source of bleeding, if there would be any specific therapy that could treat that cause, you will do it. Okay, but that would be after like giving blood, resuscitation, and so on. Okay, so history is very important. This is the like first step after resuscitation. So you have to save the patient first. You have to make sure that check the vital signs if they are stable or not. The airway, very important to check the airway. Why is that? Because it might lead to aspiration and blockage of the airway. So ABC, airway, bleeding, and circulation. So they have to be checked first, and then do the secondary scanning with the history and physical examination and so on. Okay. Investigations. So it would give you a clue about what's going on exactly. Um, Very important to check the coagulation profiles, because if there would be like a prolonged prothrombin time and coagulation disorders, it would be also a problem, because we have to fix that in order to stop the bleeding. Okay. In addition, liver function tests might give you a clue about portal hypertension or cirrhosis. Amylase lipase, it can be done in order to rule out if there would be pancreatitis, which would be caused by gallstones. Okay, and so on. Renal functions. Why are we doing renal functions with the upper GI bleeding?
Contrast.
Before that, before the contrast. It would give you an idea about the dehydration status of the patient. Okay, so with the dehydration, there would be high creatinine and BUN. Okay, so you have to give patient IV fluids. You have to give the patient sometimes, according to the CBC and the hemoglobin, you might give the patient also blood transfusion. Okay, and very important also to check blood grouping and cross match, because you would not uh, want to complicate blood transfusion with mismatch. Okay, so very important, whenever the patient will be presenting with massive upper GI bleeding, they have to insert two large IV lines. Okay, and this is for fluid resuscitation and also blood transfusion. Okay. In addition to that, as we said about the nasogastric tube and the aspiration of the gut. We might also give a PPI in order to attempt to reduce the risk of bleeding. There would be also somatostatin analog, which is octreotide, which would help in decreasing the upper GI bleeding, and so on. Next thing is to do the investigations that would help you to identify the source of bleeding. And here, emergency endoscopy, it would play a role as it has like therapeutic and diagnostic. So it might visualize where the bleeding is, and then if you identify that bleeding, you might either coagulate with heat or epinephrine. You might also, if you identify varices, you might also apply banding. Okay. After that, if endoscopy has failed, then you need to do the surgery. Okay. So for you, so this is the specific therapy onwards. All of these slides later on would talk about the specific therapies, okay, which are not of an importance for you guys, because as we said, we are not aiming to ask you about how to treat, but you need to understand the clinical correlation, how you identify the source of bleeding. Okay, so very important to know the medical background in relation to the presentation. All right, any question? All right, good luck.